The problem is that core public health laboratory functions are absolutely critical to public health surveillance and response during peacetime, that is on an ongoing basis to detect threats to public health, and even more critical during outbreaks or other emergencies where public health laboratory functions give the information that's needed to identify and characterize public health threats and to provide information to all of the partners who need to act to contain those threats to the public's health. The challenge is that core public health functions are highly dependent on skilled and specialized personnel using specialized reagents, materials, and equipment who are regulated by very structured processes for assuring high quality services that are critical both to ensuring quality results and to ensuring that results are reliable and accurate, but they are difficult to scale rapidly. Another challenge is that, or another problem is that core public health laboratory functions, while critical, are often poorly understood generally, even across public health sectors, and are often neglected in the process of public health emergency preparedness and response planning. So for anyone who has participated in an exercise or now in the real life response to the COVID-19 pandemic, it's often the case that the decisions about how the lab will respond are made in the greater public health preparedness framework, but do not directly involve laboratory personnel in scenario development, contingency planning, and the estimates of what kind of personnel and resources will be needed to ensure that systems can be surged on an ongoing basis. So what are we talking about when we talk about core public health functions? So again, apologies to those of you who come from a laboratory background, but just to make sure we are all on the same page. When we talk about the core functions of public health laboratories, this encompasses not just what many people think of immediately when they think of laboratories, that is conducting testing and returning a result, but a broader set of essential core functions that cross not just single laboratories, but laboratory systems. This graphic is adapted from a description made many years ago by the Association of Public Health Laboratories, APHL, and updated in 2014. And it lists the broad functions that are conducted through public health laboratories that are, in addition to reference and specialized diagnostic testing and confirmatory testing, equally essential to detecting and responding to public health threats. And those range from the obvious, such as training and education, partnership and communication, and integrated data management, to thinking about the role of the role of public health laboratories in supporting research, especially research to identify new countermeasures and diagnostic modes, in contributing to public health preparedness and response, developing policies, being part of the regulation of all of the laboratories in a country where they, as they relate to quality management, protecting the safety and of food, water, and other threats that are in the environment, and overall supporting disease control and surveillance. So they support disease detection. Public health laboratories support disease detection and response, both on an ongoing basis and during events through a set of 3 functions. And these are functions that were described by the US Centers for Disease Control and Prevention in overall guidance that was developed for a domestic audience to help strengthen public health emergency preparedness and response, but are equally applicable in really any setting. So the core functions of public health laboratories that are needed routinely and during events, they obviously conduct laboratory testing and report results. So the laboratories have to be public health laboratories, whether they're the reference laboratories or the network of laboratories that contribute in any given country or region to laboratory testing results. They are implementing often validating and performing methods to screen, diagnose, and confirm causes of disease, and to report that data in a timely way so that it can be used for action. The public health laboratories play a core function in enhancing communications and coordination by sharing information across all of the laboratories that constitute a national laboratory network, and then providing investigative support to other partners, both in laboratories and in public health, in emergency response, and in all of the other areas that, as we've seen during the COVID-19 response, public safety, education, transportation, and other sectors may also have key roles to play in the detection, characterization, and response to a disease threat. And finally, public health laboratories have a key role in training and outreach, both in developing and rolling out training materials and modes to support training for the laboratory workforce, and make sure that both the training and the systems are in place to support high quality testing with adequate assessment and management of biological risks, so that testing is reliable, accurate, timely, and safe, and that risks to the laboratory and to the community are recognized and managed. So again, just teasing these out and going into a little bit more detail, again, with apologies to those who routinely work in public health laboratories for which is probably a redundant review for you. But when we look at breaking these functions down, conducting laboratory testing and reporting results doesn't just begin at the laboratory itself. It begins with first the collection of, the safe shipment of, and then the receipt of specimens in the laboratory, where they have to be received, recorded, and then routed appropriately for testing under conditions that ensures they're of high enough quality for testing and reliable results. There's the actually conducting specimen sample testing. So using validated approaches. Zach, could you, I think someone has unintentionally is on an open mic, if you could help with that, please. Conducting testing using appropriate validated methods according to standardized guidance. And then reporting the laboratory results, whether presumptive or confirmed, again, in a way that is rapid enough and reaches key stakeholders so that they can take action on those results, either for managing the clinical case, that is, reporting results back down to the clinical level, so that the patient's case can be managed as effectively as possible, and reporting that information to a central location where epidemiological analysis can be combined with laboratory results for rapid action to contain the outbreak or event. The core functions include, again, laboratory communications and coordination. That is ensuring that not only results reported, but there's timely exchange of laboratory information and data between labs and among all partners. That includes ensuring that there is feedback to ensure that when specimens are referred, that they are referred correctly. There is feedback to the laboratory that referred them to confirm that the findings of both the operational functions of the lab and the results are exchanged so that the laboratories can support continuous quality improvement. And also that information is shared with all partners that is sufficient and useful for supporting public health investigations. And then finally, outreach and training. It's absolutely critical, an absolutely critical function of public health laboratories to facilitate access to training, technical training for laboratory personnel, but also training in systems, again, for quality management and biorisk management. One element of outreach that is important in thinking about preparedness for laboratories is maintaining and exercising plans for surge responses and for continuity of operations. Okay, sorry. And then I'm going to stop there for just a moment. I know that many people here have a lab background. Are there any questions or are there any comments before we move on to talking about what surge capacity is? I can't actually see you when I'm sharing my screen, so you have to actually, I'm sorry, use the function to raise your hand. Okay. I'm not seeing any questions, so moving forward, but I can be stopped from talking if you interrupt me. All right, what are we talking about when we talk about surge capacity in the laboratory environment? So this is a set of definitions from a planning tool that was developed by the Association for Public Health Laboratories in 2015 for the U.S. Laboratory Response Network, which is a network of federal, state, and private laboratories that support response to unusual events. But again, this capacity, these definitions are broadly applicable in many settings. APHL defines standing capacity as the additional volume of testing that can be absorbed by a laboratory with little or minimal change to routine operations. So in other words, with existing hours of operation, existing staffing, and without reducing ongoing routine activities, the laboratory can manage those additional samples, for example, a small or localized outbreak. Internal surge capacity was defined as the sudden and sustained increase in the volume of testing that can be supported with significant operational changes. So using existing personnel, equipment, and facilities that are already available to the laboratory network, operational changes such as going to extended hours of operation, maintaining larger numbers of personnel on shift at any one time, increasing the lengths of shifts, dedicating equipment that might otherwise be used to more routine testing to the outbreak or event response. For example, using again the SARS-CoV-2 example, using molecular diagnostic equipment such as PCR that might have been present for other testing and dedicating that equipment to respond to the surge. And using existing facilities. So essentially taking the existing stuff, staff, and systems and dedicating them to responding to this surge in the volume of testing. And then finally, APHL identified a third level of surge capacity that they called overall capacity. And I think as we've learned during the SARS-CoV-2 response, it's really a matter of systems surge capacity. So looking at the sudden and sustained increase in the volume of testing that can be supported by the laboratory network with significant operational changes, that is, dedicating personnel, equipment, and facilities to the surge and testing, and adding additional or shifted resources. So in other words, finding external resources, whether it's simply additional funding to procure more reagents, more supplies, additional shifting of personnel from other laboratory functions into public health laboratory functions. It is some sort of complement in which external resources are required to be able to deal with the sudden and increased volume of sample testing. So what have we learned? So what I'm going to share now is drawn from observations from a number of countries and a number of regional reports that try to distill down what the observations have been, not for a single laboratory necessarily, but for laboratory systems. And I'm going to just derive the bottom line up front here. Surge capacity builds on existing resources. So that sounds very trivial, but I think what we've heard again and again from laboratory experiences in every region is that it's extraordinarily challenging to import or mobilize a laboratory function that can be sustained in any meaningful way that is not based in an existing resource. So an example is the use of mobile laboratories to try to fill a gap in local capacities for specimen collection, specimen routing, and specimen testing. So we heard in many cases that while mobile laboratories actually have been used effectively in outbreak response, they work most effectively for surge capacity where they already exist. In other words, where mobile laboratories have already been planned and used as part of national response capabilities, as opposed to brought in quickly. They have been used during the Ebola virus disease outbreak in West Africa, for example, and during cholera outbreaks. But where these laboratories are provided as surge capacity externally and not as part of existing resources, they often lie outside of existing specimen transport systems, and they are often not compatible technically with other pre-existing laboratory testing platforms and procurement systems. So essentially, they provide a very short-term, they can provide a very short-term capacity, but unless they are built on an existing resource and an existing platform, they aren't sustainable in a meaningful way, and they often do not contribute in the long term to testing capacities for future events. Capacities for rapid risk assessment are essential. One element that we've heard over and over from directors of laboratory systems is that particularly in the beginning of events with emerging pathogens, for example, again, going back to the initial days of the SARS-CoV-2 unfolding outbreak, that when it is not clear what the risk is for laboratory transmission, and it is not clear what the risk is for accidental exposures that could lead to unintended exposure of the community or of the environment to a pathogen, that the ability to conduct rapid risk assessments and to communicate that information so that it can be used to develop guidance quickly is absolutely essential to ensuring that the laboratory workforce can work safely and that risks can be managed as effectively as possible. Laboratory preparedness planning pays off. Again, that seems very obvious, but because many laboratories have an enormous daily burden in terms of testing, ongoing testing, even during peacetime, they often simply do not have the time to either develop a preparedness plan or to review and exercise that preparedness plan and update it as needed. Laboratories that have developed preparedness plans for outbreaks that are external drivers and for events inside the laboratory have articulated how effectively that helped them prepare for the surge response to COVID-19 and to other events. Even if those were not the events for which they specifically prepared, they had a plan for how they would increase their staffing or their hours or otherwise change operational management as needed, and how they might respond to any event that could compromise the safety of individuals or of the entire facility of the laboratory. And then finally, stuff and systems scale more easily than staff. Even though early in any event, being able to obtain appropriate reagents for diagnostic testing may be difficult. And even though, as during the COVID-19 pandemic, shortages and challenges in shipping can cause real challenges for daily operation, overall, stuff and systems, including systems for information sharing, for quality management, and for biorisk management, are dependent on the availability of skilled and trained personnel. This is an area where everyone can easily recognize how critical it is to have a trained workforce in place. But in the laboratory, we saw during COVID-19 reliance on extensive shifts, on laboratory personnel essentially making heroic efforts day after day after day, which is not unusual for all health personnel. But in this case, having to essentially ensure that that the personnel who are deployed or who are staffing those extended shifts have the backup so that if they themselves are unable to fulfill a shift, or that if you need to expand services so that you actually have personnel in place, is not easy considering how highly specialized most laboratory training is, that task shifting is challenging, and that certification or credentialing otherwise is a major barrier during an event. This is an example that was put together by PAHO of what it means to build surge capacity on existing resources. And in this case, that existing resource is the WHO Global Influenza Surveillance and Response System, or I don't know if anyone else says GISRIS, but the backbone of reference laboratories that serve as national influenza centers that share information and share specimens in some cases during seasonal influenza and novel influenza outbreaks. So this timeline shows how in the PAHO region, that is the Americas region, the existing resources of those laboratories was leveraged to rapidly prepare for SARS-CoV-2 diagnostic testing. So what you see here in the center, the yellow line, is a rough timeline of hallmark events in the early reporting of the emerging, what we now call COVID-19 pandemic. So with the first, the notification of cases, sharing of genetic information in early January, and first cases of reporting of novel coronavirus outside China. And the rapid development of molecular protocols based on sequence data that had been reported for SARS-CoV-2, what is now the novel coronavirus, now known as SARS-CoV-2. In the Americas region, again, as one example, this is certainly not the only region where this happened, national leaders, regional laboratories, and WHO regional and country personnel worked together, building on the existing platform of national influenza centers or national laboratories that had molecular diagnostic platforms in place. The statistic here is that, in early January 2020, 0 countries in the Americas region or in any region had the capacity to do molecular diagnostic testing for SARS-CoV-2. By mid-January, the WHO offices were working on procuring testing kits, particularly focusing on the primers, probes, and kits for molecular diagnostic testing, and mobilizing them to laboratories in the region. And what you see here in this blue timeline at the top was a very deliberately staged training plan in which personnel from WHO's offices working with country personnel were able to cascade training through a series of country missions relatively rapidly to regional and national national reference laboratories by conducting training, taking advantage of regional training opportunities, by then visiting countries and ensuring that reagents were available, and basically using a deliberate cascade training approach to try to get, again, bring groups of countries together with relatively similar technological base capacities, conduct training for them so that they had harmonized and clear protocols, and then ensure that those are supported with adequate reagents and supplies. So that's the regional deployment at the top. And then what you see at the bottom in the green timeline is the timeline for the sharing of those guidelines and the actual implementation of those guidelines. So you see here, the training began in the 3rd week of January 2020. By the end of that month, the first of the countries that had been trained and had access to the protocols and the reagents in Mexico began implementing SARS-CoV-2 molecular diagnostic training. And then you see that roll out through the rest of the region, so that before the end of February, before the actual public health emergency of international concern was formally declared by WHO, every country in the region had the capacity to conduct molecular diagnostic testing at least at the central level, and to begin cascading that down. Building on the experiences in PAHO and elsewhere, and I'm just going to briefly summarize these because I want to make sure that I leave time for Rola to respond and also leave time for discussion. Observations from the Americas region, from Southeast Asia, and from the European region, where many after action reviews have been conducted and laboratorians have come together to share their observations. I should also say from Africa through the Africa CDC. Observations that have been made include the absolutely critical, the ability to search capacities, again, the ability to conduct rapid risk assessments and to make that information available to mitigate risks in the laboratories through building on existing platforms and capabilities for biosafety and biosecurity. Again and again, laboratories have highlighted the need for the ability to rapidly procure and manage testing supplies, PPE, and disinfectants. So in many reference laboratories, challenges in early procurement are not unique to the constraints of a pandemic, but something that they face on an ongoing basis. So the ability to procure and manage supplies at the central reference laboratory, and then to ensure that those supplies reach laboratories from the national level to each appropriate level in a tiered laboratory network were absolutely critical. Countries spoke to the benefits of systems, particularly communication systems that combined formal and informal platforms, to ensure that SOPs could be disseminated, SOPs and guidelines could be disseminated to all personnel, and then to ensure following up with that resources were available for effective cascade training. So to just come to these two points for one more second, benefits were cited in development of evidence-based SOPs and guidelines on a global level or a regional level, followed by convening of ideally established national laboratory committees to examine policies, SOPs, and guidelines and adapt them as needed for the local context, to disseminate them and ensure that there's actually access to them, that these are not simply available at the national level, but that they are adequately communicated and disseminated to all the laboratorians and all the laboratories that play a role, as well as to other partners. And then to ensure that, again, training can take place as effectively as possible at a centralized level and then be cascaded down using a mix of approaches, including in-person trainings, remote trainings, and in some cases, even self-training using automated or recorded materials. Established operational communication strategies. So understanding how information would be shared, including mechanisms for information sharing, was absolutely key to surging capacity and then to being able to sustain ongoing coordination and communication across all partners. And then finally, one area that was highlighted in multiple regions was a shift that in some cases happened during the pandemic to either digitizing data systems for the first time or increased use of digitized data systems with ability for rapid and centralized reporting of results and access. And then one other factor that was recognized in many regions, and this is one example that was shared by Luis Ochoa Carrera, who is now the president of APS International, who was at the time the chief of the IMSS laboratory network, that is the diagnostic laboratory, the public health laboratory network of Mexico. He shared these two graphics to show, to illustrate how prior to the emergence of SARS-CoV-2, laboratory functions across Mexico were relatively isolated. So laboratories had capabilities and there was a national specimen referral policy, but the laboratories themselves were more like, were the hub of reference laboratories. There were SOPs for referral, but the deliberate integration of laboratory networks at the regional level was very weakly realized. The second graphic here shows the regionalization of those labs during the pandemic with a much more deliberate approach to integrating specimen collection, referral, testing, and the reporting of results on a regional level to accelerate testing and to make results available as quickly as possible. So breaking down operational silos and increasing regional integration of laboratories. And what is the future for this space? Again, looking forward to this lively discussion, to Rola's comments, and then to everyone's thoughts for a lively discussion. But I think one of the issues that came up again and again in reviews of laboratory lessons observed is that laboratories can strongly benefit from the incorporation of public health emergency preparedness planning principles for laboratory functions with a focus on those core public health functions and being able to surge, and not just surge for very brief periods during an acute outbreak, but being able to sustain those surge capacities for a long time. This is a graphic that shows the traditional exercise cycle of design and development of plans, conducting exercises to test those plans, evaluating them, improvement planning, and that is again a continuous cycle. We heard from personnel from laboratories who had participated in this kind of planning and found it extremely helpful to contingency planning, anticipating threats to the lab's core functions and performance. Again, whether that's exhaustion of personnel to sustain surge capacity, or whether it's an event inside the laboratory, like a medical accident or a medical event, that this approach is extremely beneficial for laboratories. But there are a scarcity of people with both laboratory backgrounds and public health emergency management backgrounds who can help integrate this into ongoing laboratory planning. And it's an area where we can see a real need for future capacity building and future integration of public health preparedness and planning into the lab, and integration of laboratory personnel into global public preparedness and planning. So with that, I'd like to thank you, and I would like to stop and yes, I'm very happy to share the slides. I'd like to stop here and open this to first any immediate response by Rola, and then to open it up to everyone. And I'm hoping, again, lively discussion. Please love to hear your thoughts and your experiences. So Rola, turning to you for response.
Yeah. Thank you, Julie. Thank you very much. I just want to emphasize on the point of how we can sustain the surge capacity. Actually, it's the most significant thing is the leadership. So we need to train, or you need to focus on the leadership on these public health laboratories, and also in each country, and to be confident how these leadership personnel could sustain this capacity, and how they best use these capacities, and in terms of supplies, or instruments, and also the human capacities that have been built during the pandemic. So in the couple of maybe less than 30 minutes, I'm gonna give an example of how the public health laboratory in Jordan, responded to the pandemic, and how the capacity have been surged inside all, or the overall capacity as well, not only at the lab, and also overall capacity. And also we will discuss some challenges and success stories, lesson learned during that period of the pandemic response. So I'm gonna share my screen. Yeah. So can you see my screen?
Yes,
yeah, we
yes,
can see
we can.
Yes, is it great? Thank you. Okay. So Yeah, so today we are gonna present how Jordan responded to the pandemic, the COVID-19 pandemic. And so this is my outline for the coming presentations. And for whom they are not familiar with Jordan, actually Jordan is an Arabic country located within the Middle East. Its estimated population around 10.6 million, and it's divided into 12 governorates that grouped into 3 major regions: North, Middle, and South. The World Bank currently classifies Jordan as an upper middle income country. Yeah, so so the laboratory diagnostic test actually in Jordan is conducted through following channels. It's the public sector, mainly the Ministry of Health and other governmental stakeholders. It includes Central Public Health Laboratory, which is the national reference lab for all over the country, and it's also include the biosafety level 3 laboratory. Also, there is a public health laboratories at governmental hospital. At governorate. Also, there is some laboratories serving the governmental hospitals. Added to that, the Royal Medical Services, University Hospital, and some specialized hospital like King Hussein Cancer Center. Also, private sectors play a pivotal role in the domain of the laboratory. They are including private hospitals, laboratories, and network of community-based private labs. These private labs are actually operate individually or as a part of large chain. Just to highlight something here is that in Jordan, most of the laboratories are accredited with a regional and local actually accreditation. It's called the Healthcare Accreditation Council. So just to maintain and to ensure the dedication of maintaining top tier of quality and standard practices. So Jordan has established the syndromic-based surveillance system for diarrhea, hepatitis, sexual transmitted disease, and also because of that, the country understanding the importance of create a surveillance system and the importance of the response to emerging health demands. There's also effectively implementation of the SARI and ILI systems. These are also in Jordan. There is a health care associated infection surveillance that been implemented years ago, and they are related to, bacterial and fungal infections inside the hospitals. Also, Jordan implemented AMR surveillance. It's been launched in 2018 across 39 hospitals. And Jordan participating in GLASS since 2018 till now. During the pandemic, there's 3 important programs have been implemented: the acute febrile illness surveillance for detecting and the surveillance of arboviruses, also the event-based surveillance. Also, one important surveillance system is the SARS-CoV-2 genomic surveillance through the GAIN HAI surveillance that have been supported by CDC through CRDF Global. We have been actually, I've divided the response phase, period during the pandemic into 3 phases. The first phase actually was and as identified with the HR assessment mission for Jordan, and also for during the reviewing the unpublished report of WHO in 2019, there is some identified strength in Jordan that there is a well-equipped molecular unit at the reference laboratory, and there is a well-trained staff. There is a good relation and coordination, collaboration with the international agencies like US Navy units, and also CDC, CRDF, and other international partners. And also there is PCR units running. There's a running unit at the Central Public Health Lab. It's equipped with a high standard equipment and methodology. Also, there's availability of, in terms of biosafety, there's available control measures already in place, like biosafety cabinets, PPEs, SOPs, and good biosafety practices. And also there's already in place the specimen refill and transport system at that time. At that phase, actually, during this phase, the only responsible institute for testing was the Central Public Health Lab. So through this phase, there is preparation for testing of COVID. So the first commercial kits was requested and procured in February 2020. And also during our collaborative partnership, they support Jordan with primers and the probes. So through WHO, CDC, Pasteur Institute, and also because, you know, in some hospitals in Jordan, there is a rapid, molecular testing equipment like Gene Expert that have been used for identifying other pathogens like tuberculosis. So we identify on our plan, we identify this equipment to serve as rapid testing for critical cases. Yeah, actually on the second, I just wanna on the 2nd of March, the first case of COVID-19 have been confirmed, and from that time, the response against COVID-19 in Jordan was led with the government through a collaborative multidisciplinary team. This team include experts from all stakeholders in Jordan. They have been utilized the data that have been released during the pandemic to take important decisions. Also, there's so through this phase, and because CPHL is the only entity that have been conducting the testing. So, and because of the limited sources of the limited number of kits, because, you know, there is a restriction in transportation, and the companies, the vendors, companies have been like, there is some deficiencies on the kits. So, and also there is some shortage of the trained staff. So, because at CPHL, for example, in Jordan, only there was 6 trained staff who has been trained to conduct molecular testing. So at this phase, and with the exponential number of COVID-19 specimen, so there is one important challenge is that there is insufficient staff to conduct this kind of testing. And also so we have been got with the long turnaround time. Also, one of the important challenges was the lack of electronic reporting system and the shortage. There is some kind of shortage of PPEs. Also, the waste management is a very important challenge actually at that time. in phase 2, CPHL have gone through a renovation and redesign to accommodate the huge number of COVID-19 sample receipts. So at that time, some branches, some sections of the lab, because it's turned off during the pandemic, so the CPHL gets use of this department, renovate it to make the structure available for molecular testing. And also there was dramatically increase in number of automated RNA extraction machines, and also with real-time machines. Also, CPHL received the biosafety cabinets and the glove box from International Atomic Agency. Also in that, in this phase, WHO provided Central Public Health Hub with the automated PCR testing equipment. So this is a full automated machine, so it can support, because there's no need for specified staff to help in extraction steps. So here we will start with the sample and end with the results. Also, there's additional equipment for gene expert for emergency samples, especially for maybe for cancer patients or for patients who are gonna go through surgery. At that time, with a huge quantity of waste, so a validated alternative waste disposal system have been developed. So there is a proper storage and transporting of waste for other entity. It was a large hospital actually with a decontaminating unit. Also, because human resources is very important, because the trained staff are very important in this the pandemic. So there was a coordinated translocation of MOH hospital or MOH laboratory personnel through engaging volunteers such as the final year student and recent graduate. They facilitated through partnership with the Jordanian Syndicate of Nurses and Midwives, as well as USAID. Also, one of the success story, actually, it was the decentralization of COVID-19 testing. So when the pandemic hit the country with the first and second transmission waves with increasing aggressiveness, CPHL became overloaded with a huge number of samples that should be analyzed from all over the kingdom. So including those coming from suspected also patients at hospitals and point of entry and point of care centers, and those collected at epidemiological investigation team. So, and as part of the Jordanian government's national COVID-19 response, MOH collaborated with private pharmaceutical and biotechnology companies to establish a COVID-19 PCR testing unit in all over the governorate. So 100 bases of governorates have been capacity to test COVID-19 samples. In addition to participating of these companies, actually, USAID also and LHSS program supported MOH with conducting a comprehensive PCR training program for a number of MOH laboratory technicians all over the governorate, including theoretical and practical aspects, as well as a result of the testing facility decentralization. So all the service have been, conducted in all over the country. Another important part is reporting, and we to ensure dynamic reporting, because actually at the first phase, the most challenging part, in addition to other part actually, is how the results will be actively received. And because, based on these results, many restrictions have been and decisions have been done. So with the rapid surge of the COVID-19 testing, the decentralization effort led to creation of a software solution. It was called IHCAM. This program, this dashboard in the country link all laboratories that performing real-time PCR diagnosis of COVID-19 through the system. And the first step to conduct the test is that all specimen given digital barcode and test result reported to the software system, allowing MOH to track infected cases at under contact. Rapid diagnostic test at some level in 2020 and 2021, Jordanian authorities put many restrictions on the types of commercial tests to be used through the Jordanian Food and Drug Administration. And actually, the rapid antibody test, it was being approved to be used in Jordan, but the other antigen testing were not being allowed because, if you rely on that, in the community, so you will not get the proper reporting and you will not go through the route of reporting. So they will miss the contact tracing and also the number of infected people at that time. This is another success story. Actually, it was the building of the next generation sequencing unit, because on the previous phases, Jordan rely on the global variants results. So by using this facility, there were been two platform for sequencing. So by using getting the information about what variants is running, decisions have been also been affected, what kind of variants is running at that time. So this is one of the success story, and actually CPHL is undergoing now a series at that time, and the many program of training is running recently to build the capacity for the sequencing members, the sequencing technician at CPHL to enhance their capacity in not only in the wet lab and also in the bioinformatics, and also to use this capacity to in terms of other important pathogen detection, and also maybe antimicrobial resistant influenza or other emerging pathogen. As I mentioned before, the sequencing staff underwent multiple training workshops in NGS wet lab and the dry lab in bioinformatics, and these training have been conducted through Jordan partners, international partners, including DITRA, Los Elements, USAID, US CDC, and CRDF with APHL. Also, WHO provided training specifically focused on enteric pathogens, specifically on Salmonella and Shigella. These comprehensive training sessions were enhancing the expertise and capability of the sequencing team at CPHL. This is also a success story that's been built in Jordan during the pandemic. It was the public-private collaboration. It's a remarkable success story because, private sector is a very important partner. So one remarkable fact of this collaboration, it was being establishment of the molecular laboratories that I mentioned before. Also, the private companies supporting country office to establish these molecular labs. Also, some of one of the companies that have been supporting or providing the one of the equipment for sequencing equipment also support CPHL with consultation, some training, and also remotely training and coaching. As I mentioned also, the private labs actually played also a pivotal role in supporting the country's effort to help on testing a very huge number of COVID-19 specimens. With this slide, this slide mentioned the lesson learned, what lessons have been learned during the pandemic. The first one, and it seems the most important one, it is the effective leadership. Effective leadership in navigating challenges and driving success. COVID-19, it have been an experience where multi-sectoral engagement it is approved as essential for optimizing a national level laboratory response for the current, at that time, the current pandemic, and also for future epidemics. Also, strategic planning for diagnostic laboratory management at a multi-dimensional level it's a vital requirement in face of infectious disease. Also, the significance of incorporating new technologies. Like direct molecular testing, NGS, and the significance of active reporting and dashboard utilization. A very important issue is the awareness and commitment within the society. So through this pandemic, a very important lesson learned is how to maintain the high level of awareness, because the response of the people at that time, it's very important on containment of the cases of COVID-19 patients. Finally, this is my references. And also with that, I conclude my presentation. Thank you for your time and attention. And if you have any question or like to discuss any aspect further, I'm here to engage in meaningful conversation. Thank you so much. Over.
Thank you so much, Rola. I appreciate all those insights and appreciate the vivid illustration of the specific experience in Jordan and how strongly that resonates across the experience in many regions. I know we're a little bit over right now. I do want to make sure if anyone wants to ask a question or make a comment, they have an opportunity. So I know some people need to drop for other meetings, but if you have any comments or observations or questions, please feel free to ask now or indicate that now. Right, it looks like we have a group that has stayed, but I don't see any immediate questions. If anyone would like to follow up, please feel free. I think we'll make the slides available and look forward to following up with anyone who might want to continue the discussion.